right, thanks for joining highlights from the 2024 code set update. My name is Jordan Liebowitz and I'm part of the marketing team here at IMO. Before we get started with today's discussion, I want to take care of a few items for those attending. First off, this webinar is being recorded. You will also get a certificate of attendance in the follow-up email. So be on the lookout probably by tomorrow for the recording and everything. Throughout the session, all attendees will be in listen-only mode, but if you have any questions, please type them into the Q&A section on the bottom of your Zoom webinar console. We'll get to as many questions as we can, but for any reason yours is not addressed, we will follow up with you after the presentation. We like to keep things interactive, so throughout the webinar, we will be launching poll questions for you to answer. Today, we have two presenters from IMO, our Vice President of Global Clinical Services, June Bronnert, and our Director of Global Clinical Services, Shelly Jude. So with all of this being said, I'm going to pass it over to June Bronnert.
Thank you, Jordan. And welcome, everyone. Let me begin with a little background about IMO. IMO has been the primary driver behind clinical interface terminology. We began in 1994, when few clinicians were even using electronic medical records. Today, we are the premier supplier of clinical interface terminology to the U.S. and English-speaking markets, with more than 80% of acute care facilities, 4,500 hospitals, and over 500,000 daily clinician users in the U.S. alone. And we know for many organizations, resources remain tight and disruptions to the workflow is impactful. Ensuring your organization is ready for the new CPT codes effective January 1st supports uninterrupted workflows. So let's get started at looking at the 2024 CPT changes we will review today. Here are the topics. We're going to identify guideline and code changes throughout the various sections of CPT. We will review COVID-19 related code changes, differentiate the Appendix S artificial intelligence taxonomy, as well as discuss changes for various types of neurostimulators. First, let's look at the numbers. There's a total of 349 changes overall, with 225 added codes, 75 deleted, and 93 revised. In addition to code changes, there were multiple guideline revisions and additions. We will not be able to cover all the updates in this time frame, but we have selected the most relevant areas to share with all of you. So let's get started with musculoskeletal. And let's begin by looking at vertebral body tethering. What is vertebral body tethering? It is a procedure used to correct scoliosis without a spinal fusion. While a spinal fusion aligns the bones in a desired anatomical position, it prevents the bone from further growth. With a vertebral body tethering procedure, a flexible cord is used to correct the curvature. This allows for the spine to remain flexible and able to grow. The procedure involves compressing vertebral growth plates on the convex side of the spinal curvature, which inhibits growth while subsequently allowing growth on the concave side of the curvature. So what are the coding changes? You may recall there have been existing VBT codes in Category 3 section. Well, due to the increased adoption of the procedure, the 3 codes for anterior thoracic vertebral body tethering have been moved into the musculoskeletal chapter as shown here on the slide. Note the number of vertebral segments is important to determine the appropriate code for the initial procedure. A new code has been added for a revision procedure. The guideline and parenthetical notes have been revised to reflect the code changes. The spinal deformity subsection guidelines have also been revised to clarify spinal deformity, arthrodesis, and kyphectomy codes should not be reported in conjunction with the vertebral body tethering. The remaining Category 3 codes were revised as we will see on the next slide. Revision to code descriptor 0656T clarifies these codes represent the anterior lumbar or thoracolumbar region tethering. Note the codes follow the same pattern as the anterior thoracic codes in that one must know the number of vertebral segments to report the initial placement, and a code is available for a revision procedure. Next, let's turn our attention to arthrodesis of the sacroiliac joint. The Category 3 code 0775T was deleted. and a new code 27278 was added. Note the code description for the new code states without placement of a transfixation device. The existing code of 27279 has been revised to include placement of a transfixing device and should be used when the procedure requires the placement of the device. A sacroiliac joint arthrodesis is used to treat painful sacroiliac joint dysfunction, which may be due to a variety of underlying causes such as trauma, neoplastic disease, or infections. Clarification for another arthrodesis procedure occurred for 2024, as we will see next. The code family for 28292 was revised to clarify a bunionectomy is required when reporting a code from this group. Parenthetical notes were also revised to direct one to the appropriate code assignment. The last area of change we will review is related to a femur implant. A new Category 3 code was created to identify when a calcium-based implant is placed into the femur. The implant is biodegradable and designed to promote bone growth. The code description notes it is a unilateral placement, and the parenthetical notes clarify not reporting the new code with 26992, which is incision of bone cortex, or 77002, which is the fluoroscopic guidance. We will now look at neurosurgery changes. The biggest changes were to neurostimulator codes, as we will see. Starting with skull-mounted cranial neurostimulator codes, new codes were created for these devices. The devices are typically used for responsive neurostimulation. Responsive neurostimulation involves sensing and stimulating targeted areas as needed. So think about the functionality of a heart defibrillator. This device is similar, but for the brain. Based upon the sensory information, the device will fire stimulation to targeted areas of the brain. The system contains a pulse generator or a receiver along with implanted depth or cortical electrodes. 3 new codes were added, as you can see here. The codes identify insertion, revision, or replacement along with removal. We will next look at another type of brain stimulation, electrophysiological focused magnetic stimulation. The transcranial electromagnetic stimulation is applied externally to induce neural activity in the brain. A single transcranial stimulus induces a time-varying electric field in the brain that may evoke action potentials in cortical neurons. The evoked cortical potentials are measured with the goal of providing clinical insight into brain function for individuals with existing brain disease. Next, we will move on to revisions for spinal neurostimulators. The code description changes reflect technology advancements. Traditional spinal neurostimulator systems have required subcutaneous pocket creation for generator placement. The generator is then connected to the implanted electrode to power the system. Integrated neurostimulator systems are newer technology, and an integrated system does not require a subcutaneous pulse generator, as the electrode contains a receiver and the circuitry for power delivery, which comes from an external power source. Here you can see the description changes highlighted in purple. The same revisions were made to code descriptors for peripheral, sacral, and gastric neurostimulators, as you can see on this slide. The guidelines and parenthetical notes, as needed, have also been updated to reflect these changes. The last revised neurostimulator code descriptors we will review are related to the bladder. The 4 Category 3 codes shown here have been revised to specify the neurostimulation is used to treat bladder dysfunction, as highlighted on the screen. New codes were also created related to peripheral neurostimulators, as we will review next. Here you can see the 3 new codes were created for 2024, 2 for the percutaneous placement either of an initial or a replacement, and 1 code for the revision or removal of a peripheral integrated neurostimulator. The parenthetical notes and guidelines are also updated and they reflect the appropriate code assignments based upon these new codes for the integrated peripheral neurostimulator. And now let's turn our attention to cardiovascular changes. Let's start with IVL. IVL is also known as intravascular lithotripsy. IVL may be indicated for patients who have severe coronary calcifications. Patients may develop severe coronary calcifications over time due to a variety of factors, such as prior stent placement or other percutaneous coronary interventions. The fundamentals of intravascular lithotripsy are similar to the extracorporeal lithotripsy procedures that are commonly used to treat kidney stones. Shock waves are generated to target specific disease states using lithotripters. The lithotripters are located within a balloon catheter, which is subsequently inserted into the diseased vessel. The balloon is inflated with liquid to facilitate the transfer of sonic pressure waves to reach the vessel calcification. The pressure waves create microfractures within the calcification. The microfractures lead to decreasing the rigidity and the stiffness of the vessel and creating a more optimal space within the vessel to complete other desired revascularization interventions. As you can see, this new code is an add-on code for other procedures and was moved to the medicine section from the Category 3 section. Next, we will review pacemaker changes. And just as technology has advanced for neurostimulators, the same is true for cardiac pacemakers. New codes were created for dual-chamber leadless pacemaker systems. The guidelines define the systems as having 2 pulse generators containing built-in battery and electrode. The new codes are located in Category 3 section as shown here on the slide. Note the code pattern identifies when a complete system is placed, removed, or revised at the same session, or if one of the components, either the atrial or the ventricle, is placed, removed, revised at a different session. While it is common for the dual-chamber leadless pacemaker procedures to be performed during the same session, the codes do allow for reporting when one component is initially placed and the other component, such as the right atrial component, is placed at a subsequent session to create a dual-chamber system. This is important as other new Category 3 leadless pacemaker codes were created for right atrial leadless pacemaker. The codes are shown here on the slide, and the codes from 0823T to 0826T section are to be used when the right atrial leadless pacemaker is not part of a dual chamber system. So if the right atrial leadless pacemaker placement or removal is part of a leadless dual chamber system, then the codes from 0795T to 084T section should be reported. The guidelines and parenthetical notes were created, revised to lead to appropriate code assignment. Next, we will review wireless cardiac simulation system. 3 new codes, 0861T and 0863T, have been established for removal and relocation services of components of a wireless cardiac stimulator of the left ventricle. The guidelines were updated to define a complete wireless left ventricular pacing system as consisting of a wireless endocardial left ventricular electrode and pulse generator. The pulse generator has a transmitter and a battery. Code 051T to 0520T were revised to indicate both pulse generator components, which are the battery and transmitter. The codes and guideline changes help to differentiate these procedures performed for wireless cardiac stimulators of the left ventricle from left ventricular pacing devices. Phrenic nerve stimulation systems can be used to treat severe central sleep apnea. The system provides stimulation of the phrenic nerve to help control breathing. The system includes a pulse generator, which contains the electronics and a battery, along with a lead to provide the stimulation. Category 3 codes were deleted and new guidelines established. The guidelines and parenthetical notes provide instructions on different situations for reporting, such as when a separate sensing lead is necessary to augment the system, the catheterization and imaging, along with sensing lead placement at a subsequent session, removal of one or more leads, as well as repositioning, programming, and therapeutic activation codes. And the new codes we will see on the next slide. The new codes were created in the heart and pericardium pacemaker or implantable defibrillator subsection of the cardiovascular system for these procedures. Here you see insertion and removal codes. Again, the patterns are similar in that there is a code for a complete system, the pulse generator and lead, along with codes for individual components. When the system is inserted, a submuscular or subcutaneous pocket in the pectoral region is created for placement of the pulse generator. The stimulation lead is placed transvenously into the right brachiocephalic vein or left pericardiophrenetic vein. If on rare occasions a separate sensing lead is necessary to augment functionality, it may be reported with an add-on code 33277 when performed at the same session of the initial insertion. And next we'll look at the repositioning, removal, and replacement codes. Here are the new codes for the lead repositioning along with the removal and replacement of the pulse generator and sensing. And the last set of codes we will review for the phrenic nerve stimulation system are here on this slide. There were new codes established for activation and interrogation of the system. Note these codes are located in the medicine section with a new subsection titled Phrenic Nerve Stimulation System. Note the code 93150 is for therapy activation after 30 days from implantation. This allows for lead stabilization, and the three codes on the right-hand side of the screen are used to report various scenarios when interrogation may occur. Turning our attention to prosthetic valve insertions, these codes were created to report transcatheter superior vena cava and inferior vena cava prosthetic valve implantation, either via a percutaneous or open approach. This procedure may also be referred to as caval valve implantation or CAVI. Angiography and radiological supervision and interpretation used in the guidance of the implantation are included in these codes. Other Category 3 codes are seen on the slide, and so prior to 2024, no codes existed to describe thermal ablation of the nerves innervating the pulmonary arteries, so a new code was created and the existing Category 3 code was revised to distinguish between ultrasound and thermal ablation. Next, we will look at various cardiovascular-related imaging code changes. The new add-on codes are used to report congenital heart defect treatments performed via a venography during heart catheterization. They include radiology supervision and interpretation, and the guidelines are in place to define normal, abnormal, native connections, along with other coding guidance for reporting these codes. Here are the family of add-on codes for the venography for the congenital heart defects. And note the difference between 93587 and 93588 is the originating venous collaterals is what determines the appropriate code selection. Turning our attention to ultrasounds, 4 new codes with their descriptions are seen here were created to report intraoperative thoracic aorta diagnostic ultrasounds. And the next slide wraps up our review of the cardiovascular imaging, and the new code 75580 is used to report non-invasive estimates of coronary fractional flow reserves that are derived from augmentive software analysis. Shelley will discuss later in the presentation more about the artificial intelligent taxonomy, which includes augmentive services. The last new code we will review in this area is 0860T. Near infrared spectroscopy. The new code specifically identifies the service is screening for peripheral artery disease. Existing Category 3 codes were revised to indicate the screening is for non-peripheral artery disease. And our next section is vaccinations. The main changes continue to occur for vaccinations, immunizations, starting with the policy revisions. Vaccine codes are published electronically twice a year on July 1st and January 1st, according to the established immunization early release schedule. This schedule has been revised to include immunoglobulins along with vaccines. In addition to including the immunoglobulins in the early release schedule, the use of the symbol of the use of FDA approval pending will now apply to both vaccine toxoids and immunoglobulin serum recombinant products. The symbol will be removed once the FDA status changes to approval. The introduction for Appendix K, product pending FDA approval, has been revised to support this change also. In addition, IMO monitors all of the AMA sites and provides these updates via our scheduled procedure release, IT releases. The graph shows some of the immunizations that have been early released and published in the 2024 code set. To differentiate vaccine from immunoglobulin, vaccine is defined as prevention derived from live inactive bacteria and viruses, stimulates immune system to produce antibodies and provides active immunity, while immunoglobulin is defined as prevention treatment derived from existing antibodies and does not stimulate immune system to produce antibodies and provides passive immunity. Now let's look closer at the new codes. There is no specific CPT code to report adjudicated RSV vaccine for adults 60 years or greater of age, or a code that accurately describes the encapsulated lipid nanoparticles, or LNP, mRNA RSV vaccine. The new codes that were released were as follows. Code 90679. It was released on the AMA's website on May 5th, 2023, with the same effect, with the effective date of May 3rd, 2023. Code 90683 was released to the AMA website on June 30th, 2023, and will be effective January 1st, 2024. Existing CPT code 90678 differs from new code 90679 because it is not a recombinant adjudicated vaccine, nor is it an mRNA vaccine like code 90683. Two other new RSV codes are 90380 and 90381, identifying the RSV monoclonal antibody seasonal dose, which is used for infants and children less than 24 months of age. Here are additional new vaccine codes for a variety of different disease states. And the changes to the format and structure of the original COVID-19 vaccinations were revised, as the formulation of the COVID-19 vaccines used in the United States were updated to a monovalent COVID-19 vaccine with XBB lineage of the Omicron variant. This formula change led to approval of 5 new COVID-19 vaccine codes, along with 1 administration code. These replace all previously approved product and administration codes except for code 91304. Because the decision to delete these codes was made after the code book was finalized, these deleted codes in Appendix Q are included in the 2024 CPT code books, but watch for the changes to be in the 2025 CPT book. Now let's look at the new codes. Here you can see the changes we talked about on the prior slide: 5 new product codes, 1 new administration code, and 1 revised. And the next slide, we will see the deletions. As they are shown here, you can see there is a large number of COVID-19 related code deletions, and the changes also include addition and revisions of the guidelines, as well as the parenthetical notes in the evaluation and management and medicine section. And now it is time for our first poll. Jordan, will you launch the poll? As you can see, the question here is for an 85-year-old patient presents to receive an RSV vaccine, and they receive the vaccination is adjudicated recombinant pre-F. What is the appropriate code?
So is it 90679, 90683, and 90471? Is it 90381, or is it 90679 and 90471? I'm going to give it a few seconds and then you guys can find out what the answer is. All right. So June,
Yeah,
it looks like D.
and that is appropriate. D is the appropriate answer. So thank you. And with that, see, that is the correct answer. I would now like to turn the presentation over to Shelly.
Thank you, June. Pathology and labs. This will be a high level of the pathology and laboratory changes. Next slide, please. Due to limited time, I won't be going through the entire updates of the PLA codes, but would like to mention the Proprietary Laboratory Analysis Technical Advisory Group completed a review of 88 codes, 61 new codes, 10 revised, 15 deleted, and 2 Appendix O changes. Remember, Appendix O lists the laboratory or manufacturer that applied for the code. Others offering similar tests require their own PLA code or must use existing analyte, method, or unlisted codes in the Category 1 codes. Digital pathology. 0751T through 0763T new add-on codes. These new added codes are used for digitalization of glass microscope slides performed for numeric level specified. The parenthetical notes direct what existing Category 1 codes these codes are to be assigned with. Digital pathology is a dynamic image-based environment that enables the acquisition, management, and interpretation of pathology information generated from digitized glass microscope slides. Glass microscope slides are scanned by clinical staff and captured images, either in real time or stored in a computer server or cloud-based digital image archived and communication system. They're used for digital examination or pathological diagnosis, distinct from direct visualization through a microscope. This is new technology, and they're excited about the new codes that can now cover this availability. Next slide, please. Neoplasm genomic sequencing procedures and other molecular multi-analyte assays. Significant revisions and additions have occurred in the genomic sequencing procedures, guideline changes, and existing code description revisions in new codes, making new code for RNA analysis and revisions to add in the description DNA analysis or combined DNA and RNA analysis. Next code, please. Next slide, please. New codes 81457, 81458, and 81459 for solid organ neoplasm genomic sequence analysis panel. These new codes include the specific DNA, and RNA, and DNA analysis combined with DNA and RNA. This is different from previous codes that were not as specific in these areas. Next slide, please. In addition to the new codes 81462 for solid neoplasm and 81463 and 81464, these additional codes also include that additional specificity with the DNA, the RNA, and then the DNA with DNA and RNA. The AMA did share at the 2024 AMA Update Symposium this year that the genomic sequencing procedure work group are not done with their work that they are charged with in this area. The revisions of code descriptions in 2023 and the new codes for 2024 and moving to 2025, they are charged with 4 of the following issues to be addressed. 1, address current practice for expanded genetic disease carrier or diagnostic panel testing. 2, to development of code or for basic genetic disease panel testing. 3, development of a code for hereditary pan-cancer panel testing. And 4, address current practice for Lynch syndrome hereditary non-polyposis colorectal cancer panel testing. They encourage us to be waiting for these new codes and this additional growth in this area for codes in the current year and coming year. Next slide, please.
Hey, Shelly, before you begin, June, do you mind resharing your screen? A lot of people cannot see for some reason.
Okay, hang on 1 second. Sorry. If folks could provide feedback if they're seeing the slide radiology.
I can see it.
Hold on 1 second. Okay, yes, they can. Sorry, you can go ahead.
Moving into radiology section. Next slide, please. The deletion of code 74710 for pelvimetry code. This code has been deleted. And it's, deleted to reflect the current practice, along with the parenthetical notes cross-referencing the code were deleted as well throughout the book. Next slide, please. Category 3 codes for pulmonary tissue ventilation analysis using software-based processing of data from separating captured sonofluoric images. 2 new Category 3 codes have been established to report the pulmonary tissue ventilation analysis using the software-based processing through this data, 0807T and 0808T. Next slide, please. 2 Category 3 codes new in this area, 0865T and 0866T, have been established to report quantitative MRI analysis of the brain. To provide guidance on the addition of the new codes, multiple parenthetical notes have been added to instruct users on the appropriate reporting of these codes. These codes are for the analysis of the brain with comparison to prior magnetic resonance studies obtained without diagnostic MRI examination of the brain during the same session. And then the add-on code of the analysis of the brain with comparison to prior magnetic resonance studies obtained with diagnostic MRI examination of the brain for additional services. Next slide, please. We're moving into urology and gynecology. Shockwave therapy corpus callosum. There's a new code for shockwave therapy, 0864T. This is for low intensity extracorporeal shockwave therapy involving the corpus callosum, low energy. This is done due to blood vessels supplying blood to the penis can weaken as men age, while pharmaceutical options have been used. They oftentimes are temporary relief. Shockwave therapy applies acoustic pressure waves to the penis. This activates dormant growth factors, stimulates the creation of new blood vessels, removes vascular plaque, and rejuvenates erectile tissue. The treatment does not inflict pain, does not require any anesthesia or sedation, and each session lasts approximately 30 minutes. A new code for cystourethropy with urethral therapeutic drug delivery. This new code resulted in the deletion of Category 3 code 0499T. Code 52284 specifically includes cystoscopy, urethral dilation, and drug delivery using a drug-coated balloon catheter. Coated balloon technology combines mechanical dilation for immediate symptomatic relief with local drug delivery to maintain urethral patency. The technology was developed in response to patient and physician dissatisfaction with current endoscopic solutions for urethral strictures. It provides a durable, cost-effective, minimally invasive treatment option. The photo is courtesy of Laboratories Optilume urethral drug-coated balloon. I do want to mention this code description specifically calls out gender male, which is new for AMA, who typically does not call out a gender. Next slide, please. Transcervical radiofrequency ablation uterine fibroids new code. Code 0404T, transcervical uterine fibroid ablation with ultrasound guidance has been deleted. New code 58580 has been established for reporting transcervical approach radiofrequency ablation of uterine fibroids, including intraoperative ultrasound guidance and monitoring. Code 58580 is placed in the new Other Procedures subsection within the Female Genital Systems section. There is a parenthetical note, laparoscopic radiofrequency ablation of uterine fibroids, use code 58674, laparoscopic surgical ablation of uterine fibroid, including intraoperative ultrasound guidance and monitoring radiofrequency. Looking at the picture, the top portion is the graphic user interface displaced over the region where the intended ablation will take place, indicated in red, also known as the ablation zone. And the bottom portion is known as the thermal safety border, indicated in green. Adjusts automatically to the ablation zone and represents the distance where the tissue is safe from the potential of thermal damage. Please reference the revisions to exclusionary and cross-reference parenthetical notes for reporting directive. Next slide, please. Hypothermic intraperitoneal chemotherapy, HIPEC. New code 96547, intraoperative hyperthermic intraperitoneal chemotherapy procedure, including separate incisions and closures when performed first 60 minutes. And new add-on code 96548, each additional 30 minutes. HIPEC is an aggressive, targeted surgical technique that attacks abdominal cancer with fewer side effects than traditional chemotherapy. At the end of surgery to remove tumors, the patient's abdominal cavity is bathed in a heated, highly concentrated chemotherapy solution to eliminate any residual cancer. Reference parenthetical notes for a list of codes these can be used in conjunction with. Moving on to the digestive system. Adjustment to bariatric balloon, new T code. The AMA approved Category 3 code per FDA approval of this procedure in July 2023. 0813T, esophagogastroduodenoscopy, flexible transoral with volume adjustment of intragastric bariatric balloon. This code will be in the 2024 AMA CPT book. They are monitoring very closely how often this code is being used to consider it being moved to Category 1 code. This procedure is minimally invasive, non-surgical approach to treat obesity and weight-related disease. This procedure is performed by implanting an intragastric balloon system in the stomach via a 30-minute minimally invasive endoscopic outpatient procedure while the patient is under mild sedation. Once in place, the balloon device is inflated with a sterile solution. The balloon partially fills the stomach to provide a feeling of satiety. Moving into ophthalmology. Suprachoroidal injection. Deletion of Category 3 code 0465T. There is a new code 67516 used to report the administration of a drug into the suprachoroidal space between the sclera and choroid. The suprachoroidal space is a potential space between the sclera and the choroid, which is expanded with an injection of medication. Provides a more targeted approach of drug delivery, specialized needle injector, topical anesthetic. It's an aseptic technique. Slide, please. Suprachoroidal injection, new code 67516 is also to be used with the existing codes 67550 orbital implant and 67560 removal or revision. And additional parenthetic guidance for ocular implant and treatment of fractures of malar area orbit. Encourage you to make sure to review the parenthetical guidance where these codes can be used together. Next slide, please. Subretinal drug delivery injection, new code. No code existed to report the subretinal injection. Code 0810T describes delivery of the pharmacological agent into the subretinal space in the posterior segment of the eye. Typically, this was performed with a vertectomy. Next slide, please. The new code includes the injection of the pharmacological agent, the vertectomy, and one or more retinotomies. The medication is reported separately, and a list of Category 1 codes listed in the parenthetical that do not report in the conjunction with. Moving on to ENT. Ablation posterior nasal nerves. Ablation of the posterior nasal nerve is a new treatment for vasomotor rhinitis, which is characterized by a runny nose after eating or with changes in temperature. The idea is to decrease the amount of signals the nerve sends to the nasal tissue, which will in turn decrease the amount of nasal discharge and other symptoms. During posterior nasal nerve ablation, handpiece is pressed against the nasal sidewall to ablate the nerve plexus. This prevents the nerves from continually sending the signals causing your nose to run. This is a minimally invasive and safe treatment that concentrates on relieving the root cause of the issue. Slide, please. New codes 31242 and 31243. The parenthetical notes for 31242 and 31243 are used to report bilateral procedures. For unilateral procedure, the use of modifier 52 will need to be used. Auditory osseointegrated device services. Codes 92622 and 92623 describe the analysis, programming, and verification of an auditory osseointegrated sound processor, any type. These services include evaluating the attachment of the processor, device feedback, calibration, device programming, and verification of the processor performance. These codes should be used for subsequent programming when performed. There are additional parenthetical notes after codes 92601, 92602, 92603, 92604, 92620, and 92621 that you are encouraged to reference in the AMA 2024 CPT manual. Next slide. Moving into digital medicine. Virtual reality motor cognitive training. New category 3 add-on code for virtual reality facilitated motor cognitive training to be used in conjunction with existing code 97116 therapeutic procedure gait training. Includes stair climbing. This procedure combines motor and cognitive training facilitated by semi-immersive virtual reality gait for rehabilitation. Patient is attending a cognitively demanding task such as decision-making, memory, attention, and response time while navigating virtual obstacles. It utilizes a treadmill and a television screen in which patient sees a representation of their feet movement in a simulated environment. Cognitive tasks navigating to different locations, ignoring attention distractors, and spotting objects. Next slide. Pharmaco-oncologic algorithmic treatment ranking. New Category 3 Code 0794T, a rules-based algorithm, is a type of artificial intelligence system that utilizes hard-coded rules created based on human expert knowledge. Results are personalized to the treatment options for a specific hematology and oncology patient. Provides ranking of available monotherapies and drug combinations according to their ability to target the patient's specific cancer biomarkers. Professional work time to compile and submit patients' clinical data for arrhythmic assessment is included in Code 0794T. Assistive artificial intelligent descriptor code 0794T falls into the assistive category of AI based on the guidance included in Appendix S, Artificial Intelligence Taxonomy for Medical Services and Procedures. The work performed by the rules-based algorithm detects clinically relevant data, does not provide diagnosis or management decisions. The output of the algorithm requires physician or other qualified healthcare professional interpretation and report. Revisions to Appendix S. Definitions have been revised. Tables have been updated to reflect new codes, new examples to better illustrate the work performed by AI on behalf of the physician or other qualified healthcare professionals under assistive and augmentative. We encourage everyone to reference the appendices, especially Appendix S, as this has significant revisions and updates. Now it is time for our second poll question. Posterior nasal nerve ablation can be performed by radiofrequency ablation or cryoablation. True or false? Jordan, would you please launch the poll?
Yep. All right, give it a few seconds and we'll close it out. Okay. It looks like majority said true.
They are correct. The correct answer is true. There are two new CPT codes, 31224 with destruction of radiofrequency ablation and 31243 with destruction of cryoablation. Continuing on with evaluation and management updates. Next slide, please. The first item that I want to discuss is the pelvic examination practice expense only new add-on code. New code 99459 has been created to account for extra resources in pelvic examinations, which are required for preventative medicine or evaluation and management services for individuals needing pelvic exams, which can include technologies, clinician time, assistance, and facilities. These were not included in the previous work RVUs. Again, this code covers practice expense only. Code 99459 is an add-on code. An exclusionary parenthetical note has been added to guide users to the appropriate codes for which this service should be reported together with other codes. E&M guidelines significant changes, split or shared visits, multiple E&M services on the same date, and proper use of hospital inpatient or observation services. As part of rulemaking, CMS has been addressing the substantive portion of a split or shared service and who may report the service. The CPT panel determined it was appropriate to give guidance. 2024 CMS will allow current rules of history, examination, medical decision-making, or majority of time to be used. Clinicians feel medical decision-making not greater than 50% of time is most relevant when level is selected using medical decision-making. CPT codes promote team-based care. Next slide, please. E&M guidelines on split or shared. The guideline for split or shared visit states physicians and qualified healthcare professionals may act as a team in providing care for the patient, working together during a single E&M service. The split and shared visit guidelines are applied if the physician or qualified health professional performs a substantive portion of the encounter, and that physician or qualified health professional may report the service. For purposes of E&M services within the context of team-based care, performance of a substantive part of the medical decision-making requires that the physician or qualified healthcare professional approve the management plan for the number of complexity of problems addressed at the encounter and takes responsibility for that plan with its inherent risk of complications and/or morbidity of patient management. We recommend that you reference the AMA 2024 CPT manual for all of these updates and guidelines on split and shared guidance. Next slide. E&M service guidelines, technical corrections and clarifications. Again, the summary of the areas with technical corrections and clarifications you need to reference, as we do not have enough time to go through all of these. However, these are the top areas. Data test ordered and independently interpreted, independent source, management risk differentiated from condition risk, management risk, parenthetical controlled substances, online digital services and subsequent E&M within 7 days, hospital inpatient or observation care services that continuously span calendar dates, cross midnight, pre-admission consultations and prolonged services. Again, due to time restraints for this webinar, we do encourage you to make sure to reference all of these within the book. Psychedelic drug monitoring services, there are new codes. 0820T and 0822T has code language that includes who is providing the service, time taken for the service, what is done for the service, and the fact that the monitoring is continuous and in person. Exclusion guidelines and parenthetical notes have been included that restrict reporting of certain related services like psychotherapy for crises, behavioral status examination, adaptive behavioral assessment, adaptive behavioral treatment, or prolonged clinical staff services on the same date. And that concludes our portion of the webinar. I know that we are almost at time, but we do have some time for some Q&A. Jordan, if we would like to offer that.
So start putting your questions in and we'll begin answering. Just excuse any brief silence while we look at your questions. Another thing is you will get a certificate of attendance along with this recording to the webinar and a PDF of the slides. So that will be in the follow-up email tomorrow. But yeah.
Hi, this is June. There is a question around, will the webinar be covering new codes, or also talking about how the new codes will turn into added as XIMO codes. So as you can see, we did talk about the new codes and those changes as part of IMO's ongoing routine processes of maintenance. Is we do analyze the new codes and then how those codes impact IMO's terminology, which may include some remapping work or creation of new terms and code maps following our guidance and internal processes. So the other piece of that, there was a question and around, we do provide throughout our content updates what we call our release notes that has additional information around the codes and those content areas.
There was a question that came in, what are the updates in nursing facility codes 99306 and 99308? Is there any for prolonged services? For nursing facilities, there have been revisions for those codes. So they did revise the code descriptions for those codes in 2024. and those will be in our releases as well.
There's also a question around files, and as IMO has various products with the releases, we do have that information documented, available on our website with our different releases. And if there is a specific question, please feel free to reach out through our support portal, and we are happy to address anyone's specific situation around files and are being available.
Anyone who recently put their hand up, feel free to put your question into the question section. One question came in about getting the certificate. So I will include the certificate of attendance that you can give your professional association. It doesn't hold CEU credits, however, your professional association could grant them to you based on attending this webinar. All right, June or Shelly, are you seeing anything? For any question related to G2211, you can refer to your book for that. They do a great job of explaining it, apparently. All right, it looks like we are going to go ahead and close out for the day. There's a few questions that we didn't answer, but we're going to follow up with you after the webinar. Thank you for joining and working through our technical difficulties and not seeing the screen. So I appreciate that. And I hope you have a great rest of your day.